Nodular polyarteritis. Polyarteritis nodosa is a systemic vasculitis characterized by necrotizing inflammatory lesions that of medium-sized and small muscular arteries. Etiology. Cause is unknown. Trigger factors like HBV infection, hepatitis C, rheumatoid disease, malignancy, infection are possible to cause it. Clinical manifestation. Constitutional and musculoskeletal symptoms. Fever, malaise, fatigue, anorexia and weight loss, myalgia, arthralgia in large joints or less commonly arthritis. Central nervous system symptoms will see monocular blindness, arterial thrombosis with cerebral ischemia or intraparenchymal or subarachnoid hemorrhage, encephalopathy, seizures, acute or subacute myelopathy with paraparesis. In the peripheral nervous system symptoms will be mononeuritis, multiplex, distal polyneuropathy, also cutaneous neuropathy. Cutaneous symptoms will be livedo reticularis, ulcerations, digital ischemia, also nodules. Gastrointestinal symptoms will be tender abdomen with or without rigidity, guarding or dimensioned bowel sounds, gastrointestinal bleeding, bowel infarction, also cholecystitis are all the gastrointestinal symptoms. Renal symptoms will be flank pain, renal failure, and hypertension. Additional symptoms may will appear chest pain, dyspnea, palpitations, pericarditis, myocardial infarction, and congestive heart failure, blurred vision, headache, and psychosis and depression. Diagnostic criteria. Weight loss if it's more than 4 kg, livedo reticularis, testicular pain or tenderness, muscle pain, weakness, or leg tenderness, nerve disease, diastolic blood pressure greater than 90, elevated kidney blood tests, hepatitis B virus test positive, arteriogram showing the arteries that are dilated or constricted by the blood vessel inflammation, biopsy of tissue showing arteritis. All of them are the diagnostic criteria. Laboratory investigation. First of all, we have increased ESR, hypochromic anemia, leukocytosis, thrombocytosis, eosinophilia, and increased rate of the CRP in blood and hypergammaglobulinemia. Number 2, increase in rate of liver enzymes alkaline phosphate, decrease of content C3, C4 fractions of complement. Hepatitis B surface antigen is positive, also PANCA is usually positive. Instrumental investigation. We will perform angiography and we will see aneurysm. We will perform arteriogram and we will see microaneurysm. We will perform CT and MRI and biopsy. Also, we can perform Doppler ultrasound. We will see renal and hepatic aneurysms also. The last option, chest X-ray, useful for excluding other diseases. Differential diagnosis. Maybe good booster syndrome, granulomatosis with polyangiitis, IgA vasculitis, infective endocarditis, and microscopic polyangiitis will be all polyangiitis are all may be available. The treatment. Prednisolone 1 to 2 mg per kilogram. Maintains dose in 5 to 15 mg daily. Cytostatic like azithromycin 2 to 4 mg per kilogram per day. Maintains dose 50 to 100 mg per day. Cyclophosphamide 1 to 2 mg per kilogram daily orally for 10 to 14 days. Third method, antiaggregants or anticoagulants. Heparin 5000 units 4 times a day subcutaneously. Pentoxifylline 200 to 600 mg per day orally. Dipyridamole 150 to 200 mg daily orally. Santinol, nicotinate 0.15 mg 3 times a day for 30 to 40 days. Non-steroidal anti-inflammatory drugs, diclofenac 150 mg daily. Meloxicam 7.5 to 15 mg daily. Celoxib 200 mg daily. Efferent therapy we can perform also plasmapheresis, aminoglycanones, chloroquine and hydrochloroquine also can be performed. And last one, symptomatic drugs treatment of hypertension and polyneuritis, chronic kidney diseases, and etc. Prognosis and efficiency. Prognosis is unfavorable and depends on the form and speed of the disease progression. That was all.